Screen sharing option, please enable. Hello?
Ma'am, please check now.
Got it.
तुमने ग्रुप में लिंक शेयर किया?
अरे बोलो तो सही.
मैम,
Yeah.
can we start the session?
Yeah. Just 1 minute.
तुम्हारी रखा है मैंने.
Yeah, you can start.
Okay, ma'am. Ma'am, you are live now.
Okay, thank you. Hello, everyone. We are joining back after the lunch break. So I think students are still joining. So meanwhile, if you have not joined in the group, please do scan the QR code and join in the group. We'll keep you updated about the upcoming sessions also. As I think participants are still joining. Just 1 more minute, we'll start the session. So till now we have completed nerve physiology, a little bit of muscle physiology, and more important, neurophysiology is also done. So now we will move on to the systemic physiology. Let's start off with the respiratory system, respiratory physiology. So once you are well versed with the physiology basic topics, learning and revising medicine will become much simpler for you. So even though nowadays direct questions in physiology are less, but more physiology related medicine questions have been asked. So if you want to answer those type of medicine questions, you should have a thorough knowledge of physiology. So that's why whenever you are revising also, please do revise basic subjects like anatomy and physiology first, and then you move on to surgery and medicine. Don't directly go and revise these clinical subjects. It will be very difficult for you. Yes, that's why we started off with physiology. Yes, over to the systemic physiology. We'll start off with the first system, respiratory physiology. Respiratory physiology is one topic which is not at all related to us because it is full of maths and physics calculations. One reason why I chose medicine is I don't like maths, I don't like physics. Chemistry and biology is much simpler. So I'm sure most of you in this group, you won't like maths and physics. That is a very important criteria to become a good doctor. You should not like maths and physics. But respiratory physiology, I have put my best efforts to make this as simple as easy for you so that when questions are asked in the exam, you should be able to answer them. That's it. That is our only focus. Any question in the upcoming FMGE exam, you should be able to answer from respiratory physiology. Yes, over to that. We'll start off with lung volumes and capacities. There are two types of lung volumes and capacities. We have static lung volumes and capacities and dynamic lung volumes and capacities. Static means we measure this only in liters, just in liters. It is not measured over time, only in liters. Dynamic lung volumes and capacities, they are measured over time. How many liters in the first second? How many liters over a minute? If you measure it over time, they are dynamic. What are the static lung volumes and capacities? Please listen carefully. Along with me, please breathe that volume of air. As I'm telling you, just breathe that volume of air. Learning this will become very, very simple for you. Let's do a tidal volume. So how do you do a tidal volume? Just do a normal, quiet breathing. Don't put effort like this. Don't breathe like that. That is not tidal volume. Without any effort, quietly if you breathe, the curve goes like this. This is tidal volume. Normal tidal volume during inspiration 500 ml, during expiration also 500 ml. So inspiratory tidal volume 500, expiratory tidal volume 500. At the end of tidal volume, after 500 ml has gone inside, now take a deep inspiration. Like that, if you breathe, the curve goes like this. So at the end of tidal volume, how much ever air you are able to take in by a deep inspiration is called inspiratory reserve volume, IRV. By doing this, you can take in 2 liters of air. At the end of normal expiration, see 500 ml has gone out. At the end of normal expiration, now you do a forced expiration. Like that, if you breathe, you can send out 1 liter of air. 1 liter comes out. Inspiratory reserve volume is 2 liter, but expiratory reserve volume is only 1 liter. 2 liter went inside, but only 1 liter came out. What has happened to the remaining 1 liter? It didn't come out. It stayed inside your lung itself as a residue. So the remaining 1 liter, which did not come out, stays in the lung itself as a residue. That is called residual volume. If you add this, all of this, total, that's called total lung capacity, around 5 to 5.5 liters. Of all this, if you leave the one which is not vital, when you breathe, the one which is not coming out is not vital. You leave the one which is not vital, which is that residual volume, and you add all others, that is called vital capacity. You leave the one which is not important, residual volume didn't come out at all, you leave it, and you measure all others, that is vital capacity, around 3.5 to 4 liters, except residual volume, a sum of all others is vital capacity. Inspiratory capacity, IC. What is your total capacity to inspire? You can inspire a normal tidal volume, then you can inspire IRV. So you add this both, tidal volume plus IRV, because both you can inspire. That is your total inspiration capacity. What is FRC? Functional residual capacity. You add on the expiration side ERV plus residual volume. ERV plus residual volume is FRC, functional residual capacity. And FRC is called as relaxation volume of the lung. Relaxation volume of the lung. How do you measure all this? By a method called spirometry. We use spirometry to measure all this, but using a spirometry. It is a tube. You put that tube into the mouth. You ask the patient to breathe into the tube. The computer will draw all this for you. But you can measure all volumes and capacities except residual volume, because residual volume didn't come out at all. Only the air that comes out will go into the tube and the monitor will measure that. Residual volume is not coming out at all. So a spirometry cannot measure residual volume. If you cannot measure residual volume, you cannot measure FRC. If you cannot measure FRC, you cannot measure total lung capacity. So a spirometry cannot measure residual volume, FRC and TLC. So what is that method you will use for measuring these? You should use gases. Excellent, Ranjan. You should use gases which will go into your residual volume and they'll come out. We can use nitrogen washout, helium dilution, body plethysmography. Body plethysmography is an ATM box-like instrument. You go sit inside the box and you have to just breathe. That is about static lung volumes and capacities. What are dynamic lung volumes and capacities? Dynamic means we are going to measure this over time. So this is a graph, in a normal graph with time in seconds on x-axis and volume in liters on y-axis. Let's read the normal graph. FVC, forced vital capacity. This is same as vital capacity, but you do it forcefully. Like that, if you do it forcefully, that is forced vital capacity. What is your normal vital capacity? Around 4 liters. So when you do a vital capacity, you ask the patient to take a deep inspiration. You take a deep inspiration, you reach this point. From there, you ask the patient to do a forced expiration. Like that, if you do, you'll come here. This is vital capacity of 4 liter. Forcefully, if you do, that is forced vital capacity. So normal forced vital capacity is 4 liters. To send out this 4 liter, it will at least take 3 seconds for you. Out of the 3 second, how much air came out in the first second? That is called FEV1. Almost 3.3 liter will come out in the first second. So FVC is forced vital capacity 4 liter. Out of this, how much came out in the first second? 3.3 liter. That is FEV1. So we'll mark this in the graph. Normally, FVC is around 4 liters. FEV1 means in the first second, it is around 3.3 liter. This is 4 and this is 3.3. So FEV1 is 3.3, FVC is 4. Now you take a ratio. FEV1 divided by FVC or 3.3 divided by 4. So this will give you 3.3 divided by 4 will give you 83%. So what is the normal FEV1 by FVC ratio? 83%. This index is called as Tiffany index. Exactly, Ranjan. Tiffany index, normal value is 83%. It means if you are normal, out of the 4 liter, you should be able to push out 3.3 liters in the first second if you don't have any respiratory trouble. So that's how we get the 83%. 83% of the air should come out in the first second. What happens to this index in obstructive disease and restrictive disease? First, let's understand what is obstructive and restrictive disease. In obstructive diseases, there is something which is obstructing you. You have to overcome this obstruction and you have to send out the air. Now that is very difficult. To overcome the obstruction and to send out the air is very difficult. So expiration becomes a difficult process in obstructive disease. What are all the examples for obstructive disease? COPDs like emphysema, chronic bronchitis, asthma, bronchiectasis, inflammation, cystic fibrosis. In cystic fibrosis, thick mucus is a obstruction. Yes, excellent. What is a restrictive disease? If there is something which is restricting your lung, you are trying to take in air. When you try to do inspiration, lung should expand. If something is restricting your lung, lung will not expand. So in restrictive diseases like fibrosis, thickening of the lung tissue, or any foreign material is deposited, silicosis, asbestosis, lung is not expanding. So inspiration becomes more difficult. So in restrictive disease, inspiration becomes more difficult. What are the examples for restrictive disease? Fibrosis, silicosis, asbestosis, sarcoidosis, kyphoscoliosis, bending of the spinal cord, obesity, simply if you have more fat, diaphragm paralysis, myasthenia gravis. In all these diseases, inspiration becomes more difficult. It's very good, Hadia. Inspiration becomes more difficult. So now with that knowledge, let's read this. In both obstructive and restrictive lung disease, you have a lung disease, whether it could be obstructive or restrictive. Now, your FVC cannot be 4 liter because you have a lung disease. FVC decreases to 2 liter. So, in both obstructive and restrictive disease, FVC is not 4 liter, it will decrease to 2 liter. In obstructive disease, you have difficulty in expiration. So out of this 2 liter, you cannot expel out 83% in the first second because you have an obstruction. You can only push out 50% in the first second. 50% of 2 liter is 1 liter. So now FeV1 is 1 liter, FVC is 2 liters. You take a ratio, you get 50%. 1 by 2 is 50%. So Tiffany index falls to 50% in obstructive lung diseases. Normal 83%, but here it has fallen to 50%. Now, restrictive lung diseases. When you have a restriction, inspiration is more difficult. Expiration is almost normal. So since expiration is not affected, out of this 2 liter, you will be able to push out almost 1.8 liter in the first second because expiration is almost normal. You take a ratio of this, 1.8 by 2 is 90%. So the Tiffany index increases to 90% in restrictive lung diseases. This is a very simple test. You just put a tube, ask the patient to breathe. If you see Tiffany index has 83% normal. If it falls to 50% obstructive disease. If it increases to 90%, you will diagnose restrictive disease. The flow volume loop. How do we read the flow volume loop? Flow in liters per second on y-axis and volume in liters on x-axis. Flow volume loop. This machine is called peak flow meter. You put the peak flow meter into the mouth. You ask the patient to do a deep inspiration followed by expiration. When he is doing inspiration, the curve would go like this, below the baseline. When he is doing expiration, the curve goes like this, above the baseline. The black lines that we see, the black curve that you see, this is the normal curve. Let's read the normal curve first. In this normal curve, this portion which is in, listen carefully, this portion which is inside the black loop. This is the black loop. I'll trace that in laser now. This is the normal loop. This portion which is inside the loop. This portion is called the vital capacity. What is that portion? When you do from full inspiration to full expiration, that is vital capacity. So this portion which is inside the loop, this is vital capacity or forced vital capacity. If you do it forcefully, forced vital capacity. Now, what is this portion which is outside the loop? Outside the loop means it didn't come into the breathing tube at all. It didn't come out at all. Residual volume. Exactly. This is residual volume. If you add FVC plus residual volume, total lung capacity. So the portion inside the loop is FVC, outside the loop is residual volume. Add both, you will get total lung capacity. Now, this curve, this is a normal curve what we have discussed. Now we will see the right shift of this curve. Blue curve. When will you have a right shift of this curve? This one, I'll trace it in blue now. This is the right shift of the curve. The blue one. So in this curve, R for right shift, R for restrictive lung diseases. In restrictive diseases, you will have a right shift. And another R for reduced residual volume. So I'll mark the portion which is outside the blue loop. So this is the residual volume for the blue loop. Look at the black residual volume and the blue residual volume. It is less. It has decreased. Why it has decreased? Because if you have restrictive disease, there is a restriction. You are not able to inspire. So less air only you are inspiring. If you inspire less air only will go to the residual volume also. Because whatever you inspire is going into the residual volume. Less air you inspire, less goes into the residual volume. And therefore residual volume reduces. Now the green curve, this is called left shift of the curve. Now exactly opposite. Yes, quickly, what are the points for this now? Obstructive disease. Seen in obstructive disease, increased residual volume. I'll mark the residual volume for the green one. See, the portion which is outside the green loop. So much is outside the green loop. So this much is the residual volume. Residual volume has increased. Why residual volume has increased? The patient is having obstructive disease. Obstructive means more difficulty in expiration. So the patient is not able to expire. If he is not able to expire, less air only will come out. When less air comes out, more air stays inside itself as a residue. That's why residual volume increases. So in restrictive disease, residual volume is reduced. Obstructive disease, residual volume is increased. We also have another purple colored loop here where both inspiration, expiration, both are affected. Now this is seen in fixed airway obstruction. Like a tumor or a coin or a foreign body has been obstructed. So that is called fixed airway obstruction. This is how we read the flow volume loop. Over to compliance. What is compliance? Compliance means ability of the lung to stretch, stretchability. How will you measure compliance? See, when we do this for a balloon, yes, hope you remember this. I showed you. So whenever you put some air into this balloon, I'll put some pressure. See the change in volume. For the pressure that I apply, this much is the change in volume. So this balloon is this much compliant. So what is compliance? The change in volume of this balloon for the pressure that I applied. Delta V by delta P. That is why in the compliance curve also, we have volume on y-axis, pressure on x-axis. This black one is a normal compliant curve. For any value of pressure, let's say 10 centimeter of water, what is the normal compliance? How much is the change in volume? Around 5 liters. This is the change in volume. This is normal lung. What happens to this curve in fibrosis? Now let's apply the same pressure of 10 centimeter of water, but the change in volume is only 2 liter. Normally it is 5 liter, but in a fibrosed lung, it has decreased. Now, if this is a fibrosed lung, fibrosis means thickening of the lung tissue. There is scar tissue. So, how much ever pressure you apply, see, only this much it is expanding because there is a fibrotic scar tissue. Change in volume is very less. So, compliance has decreased in fibrosis. What happens in emphysema? Emphysema is a condition where all the individual alveolar septa are all damaged. So all of them will join to form a big sac which can expand very well. Now this sac will expand very well. So now what happens when you apply the same pressure, the change in volume is almost 7 liter. So compliance has increased in emphysema. Fibrosis compliance decreases, emphysema compliance increases. One of the important factors which affects compliance is surfactant. And surfactant, let's quickly learn about surfactant. What is the role of surfactant? Listen carefully. If I take some water and I'll pour it on the table. Whenever water comes in contact with air, if these are all water molecules, they will always have a tendency to attract to each other. Why they are attracting to each other? Because of surface tension. Surface tension only is attracting all these molecules close to each other. So what is this surface tension doing? It is attracting the molecules and making it smaller. If this happens on the alveoli, what will happen? All this attractive force will make your alveoli like this. So the alveoli will collapse. So what is surface tension doing? It is collapsing the alveoli. Repeat question. Surface tension collapses the alveoli. But our alveoli are not collapsing because we have surfactant. What will surfactant do? It will destroy all the surface tension. If you destroy the surface tension, alveoli will not collapse. So surfactant prevents alveolar collapse. If a baby is born with surfactant deficiency, now what will happen? If there is surfactant deficiency, yes, alveoli will collapse. Alveolar collapse. This is called infant respiratory distress syndrome or hyaline membrane disease. This is based on Laplace law. So the law which relates to surface tension and surfactant is Laplace law. Pressure is equal to twice the tension divided by radius. This is Laplace law. Pressure is equal to twice the tension divided by radius. Now, if you identify surfactant deficiency in a newborn baby, infant respiratory distress syndrome or hyaline membrane disease, how will you treat this baby? The baby is already born with surfactant deficiency. There's no surfactant. So how will you treat this baby? Yes, steroids you can't give now because already the baby is born with surfactant deficiency. So you have to give Survanta, leucinactant, beractant. These are all surfactant replacement therapies. So when you give Survanta, leucinactant, beractant, artificial surfactant, that will help the baby to breathe. Now, this is all after birth. If you identify this defect before the birth of the baby, in utero itself, around 28 to 32 weeks of gestation. Why only 28 to 32 weeks? During this period only, surfactant synthesis increases. So if you had identified this in the fetus itself, now how will you treat this? You will do tests for fetal lung maturity. What are the tests that you will do? LS ratio, lecithin to sphingomyelin ratio. If it is less than 2, it indicates surfactant deficiency. You can do a bubble test, shake test or Clement test. Take some amniotic fluid, put it into a test tube and shake it. If you see bubbles coming out, only lipids will produce bubbles. Lecithin and sphingomyelin will produce bubbles. If you don't see bubbles, surfactant deficiency. Or lamellar body count. Lamellar bodies are storage organelles of the surfactant. If lamellar body count is less than 30,000, it means surfactant deficiency. So these are called tests for fetal lung maturity. It should be more than 30K. Yes, if it is less than 30K, it is surfactant deficiency. So these are all the tests done to identify fetal lung maturity. So if suppose you identify this in utero itself, now how will you treat? Yes, you give steroids to the mother because steroids have the tendency to increase surfactant synthesis. So by the time baby is born, surfactant synthesis would have increased in the baby. So this is about fetal lung maturity. Over to transport of gases. Transport of oxygen, transport of carbon dioxide. How is oxygen transported? From the alveoli, and oxygen diffuses into the pulmonary capillary. What is the fate of this oxygen? 97% of this oxygen will enter into the RBCs. This is a RBC, and 97% of this which goes into the RBC combines with hemoglobin. This is called bound form of oxygen. The remaining 3% stays in the plasma as the dissolved form. It is dissolved in plasma. According to Henry's law, dissolved form of any gas is directly proportional to its partial pressure. This is called the unbound form of plasma. Unbound form of oxygen. So bound form 97%, unbound form 3%. What is the function of this bound form? Along with hemoglobin, it will be carried to all the tissues. What is the function of this unbound form? Contributes to partial pressure of oxygen. Transport of carbon dioxide. All tissues release carbon dioxide. Tissues will release carbon dioxide into which blood? Venous blood. So this is veins, venous blood. This CO2 enters into the venous blood RBC. Venous blood RBC. What is the fate of this CO2 which enters into the venous blood? This CO2 combines with water to form H plus and bicarbonate. Now, what is the fate of this? Yes, 23%. Excellent. 70% is transported as bicarbonate form. Now, what is the fate of this bicarbonate? This bicarbonate moves into the plasma in exchange for a repeat question. This is your recent repeat question. Bicarbonate moves into the plasma in exchange for another anion which enters inside, which is that chloride. What is this shift called as? Yes, Hamburger's shift. This is Hamburger's shift. Bicarbonate moves into the plasma. In exchange, chloride moves into the RBCs. Hamburger's shift. This is how 70% of CO2 is transported. The remaining, some of the CO2 combines with hemoglobin to form carb amino compounds. Carb amino compounds. This is 23% as carb amino compounds. 70 plus 23 is 93. The remaining 7% stays dissolved in the plasma. What is the role of this one? This dissolved form is directly proportional to partial pressure of carbon dioxide. This is how CO2 is transported. Major transport from 70% along with bicarbonate, 23 as carbamino compounds and 7% staying in the plasma. ODC curve, oxygen hemoglobin dissociation curve. Very important. Almost every year we are seeing questions from this. So listen very carefully. This is a normal curve with partial pressure of oxygen on x-axis and percentage oxygen saturation of hemoglobin on y-axis. It means hemoglobin is how much bound to oxygen. Hemoglobin is how much saturated with oxygen. That is on the y-axis. Now, when partial pressure of oxygen is 100 in the systemic arterial blood, normally partial pressure of oxygen is 100. So in PO2 is 100, you look at the saturation, your body is maintaining almost 100% saturation or 97.5% saturation. When PO2 falls to 60, now see the saturation, it is almost 90%. Hemoglobin is 90% bound with oxygen. This is called safety factor. Even if your PO2 falls to 60, still your body is able to maintain 90% saturation. That's why safety factor. When PO2 falls to 27, look at the saturation, only 50%. Hemoglobin is 50% bound with oxygen. This is called P50. The partial pressure at which you have 50% saturation. P50 value is 27 millimeter of mercury. Now this is a normal curve. This curve can be shifted to the right or to the left. What are the causes for right shift and left shift of this curve? So in right shift of the curve, if the curve is shifted to the right like this, R for right shift, listen carefully, this is the most important part. R for right shift, R for release of oxygen to tissue. So whenever there's a need to release oxygen to the tissue, curve shifts to the right side. When will you have a need to release oxygen to the tissue? In hypoxia. If a tissue is hypoxic, it means it needs oxygen. You have to release oxygen to the tissue. And exercise, when you do exercise, exercising muscle needs more oxygen. So all this will cause right shift. Right means very important. Listen, right means something good or increasing. So we will place all increasing factors. Increase in H plus, increase in CO2, increase in temperature, increase in 2,3 BPG. Increase in 2,3 BPG is caused by growth hormone, thyroid hormones, and sex hormones, androgens. So growth hormone, thyroid hormone, and sex hormone also will cause right shift of the curve. And this right shift of the curve, when you release oxygen to tissue, it means you are removing oxygen from hemoglobin, releasing it to the tissue. So hemoglobin oxygen affinity will decrease. Hemoglobin oxygen affinity decreases. Only then you can remove oxygen from hemoglobin, you will release to the tissue. So this affinity is decreasing. And this is called Bohr effect. R for right shift, R for Bohr effect. Yes. Now, left shift of the curve. if the curve shifts to the left. Left shift, you remember, tissues are left without oxygen. Left shift, tissues are left without oxygen. If the tissue is left without oxygen, where is all the oxygen? It is with hemoglobin. So there is increased hemoglobin oxygen affinity. The tissues are left without oxygen. It means all this oxygen is with hemoglobin itself. Hemoglobin oxygen affinity is more. So this is left shift of the curve. What are the causes for left shift of the curve? Left means something bad, left. So we'll put all negative factors. Decrease in H plus, decrease in CO2, decrease in temperature, decrease in 2,3 BPG, and also fetal hemoglobin, and also stored blood. All this will cause left shift of the curve. Please understand one thing. In right shift of the curve, there is increase in H plus. It means acid is increasing. When acidity is increasing, pH would decrease. So we said all increasing factors, but not pH. Because if acid is increasing, pH will decrease. So pH decreasing will cause a right shift. Similarly, left shift, acid is decreasing, H plus is decreasing. If acid is decreasing, it means pH is increasing. So all decreasing factors, but not pH. pH will be an exception to both the sides. Next, let's move on to regulation of respiration. Neural control, chemical control. Neural control of respiration means how your brain controls respiration. In brain, there are pontine centers and medullary centers for respiration. Now, what are the centers in pons and medulla? So in medulla, we have pre-Botzinger complex, dorsal respiratory group, and ventral respiratory group. Pre-Botzinger complex. This is the pacemaker for breathing. The first impulse for breathing comes from pre-Botzinger complex. If there is any damage to the pacemaker, this results in Ondine's curse. Ondine's curse. Yes, Dr. Ranjan. Metabolic alkalosis in right shift. Yes, see, look at this. What are the factors which cause right shift? Increase in H plus. When you say increase in H plus, it means it is acidosis. It is not alkalosis. It is acidosis, doctor. Metabolic alkalosis is left shift. Because in left shift, acid is decreasing, pH is increasing. This is alkalosis. So left shift is alkalosis, okay? Any damage to pacemaker, Ondine's curse. DRG, dorsal respiratory group. This is responsible for inspiration. VRG, ventral respiratory group, forced expiration. This is not normal expiration, forced expiration, because for normal expiration, you don't need any centers at all. The air that goes inside will come out. We don't need center at all. Only for forced expiration, like if you hyperventilate or you climb on a mountain, you sing on a high pitch, you take a deep breath. When you do all this, that is forced expiration. These are all the medullary centers in the medulla. Over to pontine centers. Pons has upper pons and lower pons. Upper pons has pneumotaxic center. Pneumotaxic center is the switch between inspiration and expiration. This will tell you when to switch between inspiration and expiration. It will tell you stop doing inspiration, go to expiration. If there is any damage to this pneumotaxic center, the switch is lost. So you can't quickly switch from inspiration to expiration. So this results in slow breathing. You will keep on doing inspiration. So breathing slows. Slow breathing, and therefore tidal volume increases. This is pneumotaxic center damage. Lower pons has Apneustic center. Apneustic center can prolong inspiration and cause apnea. Apnea means cessation of breathing, stopping of breathing. Temporary stopping of breathing is called apnea. So these are the pontine centers and medullary centers which will help you in breathing. There's one important nerve for breathing, vagus nerve. Now what? Dive. Very good, very good. The mnemonic is dive. DI. Dorsal group inspiration, dorsal respiratory group inspiration. VE. Ventral group expiration. That is dive. DIVE. Dorsal group inspiration, ventral group expiration. What is the role of vagus in respiration? Vagus and pneumotaxic center both have common functions. Two common functions. Both can inhibit inspiration and both can inhibit apneustic center. Both can inhibit inspiration, both can inhibit apneustic center. Therefore, if you have any damage to both vagus and pneumotaxic, now there is no inhibitory control over the apneustic center because both inhibit apneustic center, both are lost, there is no inhibitory control. Without inhibition, apneustic center activity decreases, therefore causing apnea. So if there is any damage to only pneumotaxic center, if vagus is fine, slow breathing, tidal volume increases. But if you have a damage to both vagus and pneumotaxic, then the patient will develop apnea. This is neural control what we saw. Now chemical control of respiration. Two important chemicals, oxygen, carbon dioxide. They control respiration. So first we'll do the central control of respiration. Central chemoreceptors. C for CO2. So central chemoreceptors are more sensitive to C for C, CO2. What is the mechanism of central chemoreceptors? If this is the blood and the brain, between the blood and the blood-brain barrier. Whenever carbon dioxide level increases in the blood, this CO2 will cross the blood-brain barrier. It will enter into the brain. CO2 combines with water to form H plus and bicarbonate. Now what is the fate of this H plus? The H plus will directly stimulate the central chemoreceptors on the brain. When you stimulate the central chemoreceptors, the patient will start breathing. So increased CO2 itself is a stimulus for breathing. So listen, increase in blood level of CO2 or increase in brain levels of H plus, both can stimulate central chemoreceptors. And also remember, a fall in BP also can stimulate central chemoreceptors because we have a chemoreceptor reflex for regulation of blood pressure. So central chemoreceptors can also sense hypotension. Over to peripheral chemoreceptors. Peripheral chemoreceptors, they are located on the periphery. Periphery means carotid body and the aortic body. They are located on aortic body is on the arch of aorta, carotid body at the bifurcation of internal and external carotid artery. Now they have specialized cells called glomus cell. This is a glomus cell. Whenever there is fall in the partial pressure of oxygen, it means there is hypoxia. This hypoxia will be sensed by hypoxia sensitive potassium channels through which potassium goes out. On the glomus cell, this is a glomus cell. Glomus cells are present on the carotid body and aortic body. These glomus cells have hypoxia sensitive potassium channels which will sense hypoxia. So whenever there is hypoxia, this channel will close. What will happen if this channel closes? Potassium cannot come out. So potassium begins to accumulate inside the cell. Potassium is a positive ion. Whenever positive ion accumulates, voltage will increase and this will open up voltage gated calcium channels and calcium enters inside. What is the role of calcium? Anywhere you have calcium, it will push the vesicles to release the neurotransmitter. Here the neurotransmitters are dopamine and ATP. What is the function of this dopamine ATP? They will stimulate two nerves, ninth and 10th cranial nerves, glossopharyngeal and vagus nerve, and they will go into the brain and they will stimulate DRG. Excellent, Ranjan, DRG. When DRG is stimulated, you will start doing inspiration. See, that's how whenever there is hypoxia means oxygen is decreasing, all this will happen. It will make you to do inspiration. So the most potent stimulus for peripheral chemoreceptors is fall in the level of oxygen. That is the most potent. But keep in mind, peripheral chemoreceptors can also sense increased CO2, increased H plus and hypotension. So hypotension is common for both. Increase in CO2, increase in H plus also common for both. Peripheral, especially to oxygen, that only is different. Otherwise, CO2, H plus, BP. All three are common for both central chemoreceptors and peripheral chemoreceptors. Periodic breathing or altered breathing. Abnormal breathing patterns. Eupnea means normal breathing. Tachypnea is fast breathing. Bradypnea is slow breathing. What are the pathological variations in the breathing? The first one, Kane-Stokes breathing. You look at the pattern, it goes up, comes down, then there is no breathing. This is called waxing, waning apnea or crescendo, decrescendo apnea. This is a regular pattern physiologically seen in sleep, high altitude and infants. Pathologically seen in heart failure patients. This is Kane-Stokes breathing. The other one, Biot's breathing. In Biot's breathing, there is no pattern at all. It is very irregular. So Biot's is an irregular type of breathing. Incoordinated breathing. Incoordination is called ataxia. So it is called ataxic type of breathing. Where this will be seen in damage to pons because pons has two important centers, pneumotaxic, apneustic. If both are damaged, you will see irregular breathing. The next one, very important, Kussmaul's type of breathing. Look at this. It's regular, it's fast, but it is very deep. So deep respiration, regular, fast and deep breathing. What is a mnemonic? The word Kussmaul itself. What are the causes for Kussmaul's breathing? K for ketoacidosis, U for uremia, S for sepsis, another S for salicylic acid poisoning, M for methanol, A for aldehyde, and L for lactic acidosis. Yes, KUSSMAL. These are the altered breathing. It's over to acid-base balance. So, very important topic. I'll just teach you the basics of how to diagnose acid-base disorders. So, if a question is given, how will you arrive at the diagnosis? First basic rule is, what is the normal pH of the blood? 7.35 to 7.45. This is the normal pH of the blood. Only within this pH, all enzymes and hormones can act. That's why this is the normal pH range. If any pH goes less than 7.35, you call it as acidosis. If it goes more than 7.45, alkalosis. Good. This is acidosis and alkalosis. So first step, when they give you a question on acid-base balance, you identify whether it is acidosis or alkalosis from the pH. Number 2. So first step, from the pH, you have identified less than 3.5 as acidosis and more than 7.45 as alkalosis. Yes, second step. You look at the values of bicarbonate and carbon dioxide. This will be given in the question. Bicarbonate and carbon dioxide. Normal value of bicarbonate is 25 milliequivalents. Normal value of CO2 is PCO2 40 to 46 millimeter of mercury. This is the normal value. But in the question, if you see that bicarbonate is the cause of the problem. If you have identified acidosis or alkalosis, but if the cause of the trouble is bicarbonate, you diagnose it as metabolic acidosis or metabolic alkalosis. If you find out as bicarbonate is the cause, if bicarbonate is the cause, then you will give this as metabolic. Because bicarbonate is the one which will neutralize H+. H+ is a metabolic acid. So bicarbonate is the cause, metabolic. Number 3, you find out that CO2 is the cause. CO2, carbon dioxide, is a volatile acid because it will form carbonic acid. So CO2 itself is an acid. If you find out that CO2 is the cause, CO2 means something related to lung. If lung is the cause, you name this disorder as respiratory. Very good, Swanil. Respiratory. So clear? With the pH, find out acidosis or alkalosis. Look at the bicarbonate. If bicarbonate is the cause, then it is metabolic. If CO2 is the cause, it is respiratory. And remember, if there is any trouble with the metabolic or the respiratory side, the other will balance for this. It will compensate for this. So if you have any metabolic disorder, lung will compensate. That is called respiratory compensation. Yes, 22 to 27 around is the bicarbonate value, Dheeraj. If there is something wrong in the respiratory, if you have respiratory acidosis or alkalosis, your kidney will compensate. That is called metabolic compensation or renal compensation because bicarbonate is absorbed by the kidneys. So if there is something wrong in the metabolic side, respiratory compensation. If you have a respiratory problem, you will have metabolic or renal compensation. This is a simple rule. Yes, with that knowledge, let's try to solve this. So first question, I'll tell you how to do. Other questions you have to do. So pH of 7.65. Stepwise we'll do. Please all of you follow. If pH is more than 7.45, what is your diagnosis? Alkalosis. It is alkalosis. So your diagnosis is alkalosis. Now, bicarbonate normal value 25. It has increased to 39. PCO2 normal value is 40. It has gone to 55. So both have increased. Now see which is more matching with your diagnosis. PCO2 increasing, can it cause alkalosis? PCO2 is an acid. Carbon dioxide is an acid. If acid is increasing, if this is the cause, it would have caused acidosis only. It cannot cause alkalosis. PCO2 increasing cannot cause alkalosis. It would have caused acidosis only. So this is not the cause. Now, bicarbonate has increased. Bicarbonate is a base. It is an alkali. If alkali increases, can it cause alkalosis? Yes. So this only is the cause. So you have identified bicarbonate as the cause. If you identify bicarbonate as the cause, how will you give your diagnosis as? Metabolic. Yes, it is metabolic alkalosis. So whenever you have metabolic problem, who will compensate? Respiratory compensation with respiratory compensation. What is that respiratory compensation? As a result of compensation, PCO2 has increased in the same patient. This is the compensation. Why PCO2 has increased? The patient is suffering from alkalosis. Alkalosis means already his body has lot of alkali. In order to neutralize this alkali, what the lung will do? Lung will breathe slowly. It will accumulate CO2. If you accumulate more CO2, this CO2 can neutralize the alkali. So the answer is metabolic alkalosis. with respiratory compensation. Yes, just C. It is not D, it is C. Yes, Ranjan, yes. So this is metabolic alkalosis with respiratory compensation. Now I'll show you one problem. I want all of you to try and get an answer. Yes, all of you will wait. All of you get an answer and type. Just follow the same steps and do this. Yes, we've got 1, 2, 3 answers. 4. Siddhi, Swanil, Ranjan, iPhone, almost all of you have given the same answer. Any different answer? Adi, Hadia Syed. Excellent, all of you. Right answer, metabolic acidosis. So how did you do this? pH is less than 7.35. So the diagnosis is acidosis. Bicarbonate has decreased. PCO2 also has decreased. Can decrease in bicarbonate cause acidosis? Yes, bicarbonate is a base. If alkali base is decreasing, automatically it will go for acidosis. So bicarbonate only is the cause. If you identify bicarbonate as the cause, then it is metabolic. So it is metabolic acidosis. Who will compensate? With respiratory compensation. What is that respiratory compensation? What the lung has done? Already body is in acidosis. You have too much of acid. So what the lung will do? It will breathe very fast, send out all the CO2. CO2 wash out. CO2 is an acid. If acid goes out, acidosis can be controlled. That is why CO2 washout has happened and CO2 has decreased. Yes. So this is a case of metabolic acidosis with respiratory compensation. Can you all try this? Yes, I want all of you to try this. What is the answer? Yes, very good, Swanil. Others, please give me an answer. C. All of you see. Very good. So this is pH more than 7.35. Alkalosis. Bicarbonate has increased. That has caused alkalosis. Yes. So it is metabolic alkalosis. Who will compensate? Respiratory compensation. What is the respiratory compensation? Already body is in alkalosis. So what the lung will do? It will breathe slowly, accumulate more CO2. The CO2 will neutralize the alkali. So as a result of compensation, CO2 has increased. So it is metabolic alkalosis with respiratory compensation. Yes. Why you didn't go for option E? What is option E? There also you have metabolic alkalosis. Why you didn't choose that? Because it is uncompensated metabolic alkalosis. Option E is uncompensated. See, as a result of compensation only, CO2 has increased in this patient. If compensation has not started, CO2 would not have increased. This would have been normal. If in the same patient, if PCO2 was normal, it means compensation has not started. That is uncompensated. Because PCO2 has changed, it means compensation has happened and that is why PCO2 has increased. So if in the same patient PCO2 was 40, then you will go for option E, uncompensated metabolic alkalosis. Yes, we have finished the respiratory system. Over to cardiovascular system. Just a minute. Yes. Yes, it has just started, Ranjan. In the case that I showed you, partial compensation has happened. That is correct. But in the same case, if PCO2 was normal, then we will go for the uncompensated. The answer for the question that I showed you is compensation only. Correct. Yes, most of you, even though I'm not able to see you, I'm able to feel you. So most of you, after post lunch session, you are like this. So what we'll do, we'll just wait for 2-3 minutes. You just check your Instagram reels. You just go through some of the notifications, drink some water. So we will just, this is not a break, just will be online only. So just 2-3 minutes, all of you relax, do your hands and legs like this and all. After 2-3 minutes, I'll just continue. Dheeraj, you want MCQ? Okay, sure, sure. We'll do MCQs also. Yes, all of you. Are you all there? We are just joining back. Yes, are you all there? Yes. Since some of you wanted MCQ discussion, so I'll just show you a few MCQs in respiratory. We'll do that and then we'll move on to the CVS. Just see if you're able to answer this. Yes, all of you wake up, please. What is the answer for this? Relaxation volume of lung, which is called relaxation volume of the lung. I told you, at the end of normal expiration, lung is relaxed. What is that volume of air in the lung at the end of normal respiration? At the end of normal expiration, lung is said to be in a relaxed state. FRC, not residual volume. At the end of normal respiration, see, I'll show you that again. Look this. At the end of normal expiration, lung is said to be in the relaxed state. So at the end of normal expiration, the volume of air that is there on the lung is ERV plus RV. ERV plus RV is FRC. So it is FRC, functional residual capacity. So when you do a normal expiration, lung is relaxed. So it is FRC. This one, which is inactive during a normal respiration. Pre-Bonsinger, don't say pre-Bonsinger. Pre-Bonsinger is the pacemaker. Normal respiration. So which is responsible for forced expiration? VRG is responsible for forced expiration, not for normal expiration. For normal expiration, you don't need center at all. I told you, right? A normal expiration, it will automatically happen. Only for, what is DIVE? DIVE. Dorsal inspiratory, ventral expiratory, but not normal expiratory. It is for forced expiration, only for forced expiration. Others all play a role in normal respiration. VRG not in normal respiration, only for forced respiration. This one. What is the answer? Diabetic ketoacidosis, DKA. Yes, this is Kussmaul's type of breathing. Kussmaul's type of breathing. Rapid, deep breathing. C. Very good. All of you for C. This one, already it is there. See, thin-walled, delicate blood vessels like capillaries, less prone for rupture. So they're talking about pressure. Rupture means tension and size. Size is radius. So the law which relates pressure, tension and radius is Laplace law. So we'll go for Laplace law. What is Frank-Starling's law? Yes, what is Frank-Starling's law? This is for, yes, in the heart, in CVS. Preload is directly proportional to stroke volume. This is Frank-Starling's law. What is Poiseuille's law? Poiseuille's law in CVS. The flow is directly proportional to fourth power of radius. This is Poiseuille's law. What is Fick's law? Fick's law of diffusion. Diffusion is directly proportional to concentration gradient into area of diffusion into solubility divided by thickness into size of the diffusing particle. This is Fick's law of diffusion. And we also have Fick's principle for cardiac output. Yes. So the answer to this question is Laplace law. Can you do this? Try, all of you try. Nobody? Ranjan, Dheeraj, Some of you are saying A, some of you are saying B. Dev's iPhone. Why did you say A? First, all of you write the formula. Yes, Ranjan, Hadias, right? Write the formula for compliance. What is the question? Calculate the compliance. What is compliance? Compliance is equal to change in volume by change in pressure. What is the change in volume? During a spirometry experiment, 40-year-old female instructed to inspire from a spirometer. She was able to inspire 400 ml. So how much is the change in volume? 400 ml she is inspiring. So change in volume is 400 ml. The intrapleural pressure varies from minus 2.5 centimeter before inspiration to minus 6.5 centimeter after inspiration. So the pressure is ranging from minus 2.5 to minus 6.5. So what is the difference between minus 2.5 to minus 6.5? Yes, it is 4. There is a 4 centimeter pressure change. So change in pressure is 4 centimeter of water. 400 by 4. So this will give you 100 ml per centimeter of water. Yes, all of you, those who have done it wrong, please check this. This one. Pneumothorax. What will happen to lung volume and thoracic volume? Pneumothorax means if you have air in the pleural cavity between your lung wall and the chest wall, if you have air, what will this air do? Air will expand. So this air will push the chest wall outside. So this is the lung inside, and outside you have the chest wall. In between lung wall and the chest wall, you have air, that is pneumothorax. This air is expanding. It will push the chest wall outside. If it pushes the chest wall out, the thoracic cavity will increase. So thoracic volume increases. And this is going to push the lung inside. So lung is going to collapse inside. If the lung collapses, lung volume will decrease. So this air will push the chest wall out, it will push the lung in. So thoracic cavity increases, lung volume decreases. This is also a recently asked INICET and NEET question. Yes, over to cardiovascular system. The few of the queries that student had messaged me to clarify, not about the subject, just generally for your preparation as you're nearing your exams. The first thing was about, some of you were asking me, Mama, I'm not all able to sleep in the night. I'm able to sleep in the class, but I'm not getting sleep in the night time. See, I'll tell you one thing. Before your exams, if you keep a fixed schedule for sleeping, if you fix like this, I'm going to sleep at 11 p.m. and I'm going to get up at 5 a.m. in the morning, that will never happen. So don't fix sleep schedule, because if you think that you have to sleep at 11 o'clock, it will take at least 2 hours from that for you to sleep. Your mind will be psychologically set like that. So if you don't get sleep, what will you do? You just keep on reading. You read and read. At one point, you will feel sleepy. Whenever you feel sleepy, you just close the book and you sleep off. And don't have fixed duration for sleeping. It is not necessary for you to sleep 7 to 8 hours in a day. Just having few days for exam to go. Compromise your sleep. That's okay, because you have only few days for your exams. It is okay even if you sleep 4 to 5 hours. That's more than enough. Don't think about sleeping for this much hours. I'm not able to sleep for this much hour. That will more and more give you stress. So don't fix your sleep schedule. Whenever you get sleep, you sleep. Whenever you get up, you sit and read. Spend more time in reading. Don't think about sleeping. The other thing that I'll send the MCQs also, Dheeraj, don't worry. Other thing some students were asking, ma'am, I'm feeling very stressed. I'm feeling very depressed. See, to be very frank, if you announce an exam for anybody, even feeling very anxiety, feeling very pressurized. See, I'll tell you one thing. I have 10 years of experience in physiology, but still now you tell me, ma'am, I'm going to give you an exam. Next 1 hour, I'm going to give you 100 marks of question paper. I will get tensed only. I will get anxiety only. See, that is nature. By nature, if you give exam for anybody, I have a son in second standard, you tell him, I'm going to give him an exam tomorrow, he'll be very exhausted and tired today, anxiety today. If you tell anybody to write an exam, anybody will get tensed. That is nature. Don't try to alter the nature. So it is your inborn human nature that you are getting anxiety. That will happen. When will all your stress, depression, anxiety go away? Once your exam is done and you pass your exams, you clear your exams, automatically all that will fly away. So now don't struggle yourself to come out of this anxiety and stress. You can never come out of that. Any person on earth is going to write an exam will be tensed only. You give yourself an acceptance. So you have to accept yourself. Yes, I'm going to give an exam. That's why I'm very tensed. Once my exam is done, I'm going to pass my exam. I'm going to be the most happiest person. So you fix your framework like this, and you fix in your mind that what are all the beautiful things that are going to happen to you once your exams are over and you pass your exams. So on the other side, you have a very much beautiful life waiting for you. It might be a good job, a good PG seat, a beautiful girl or a boy, someone is waiting for you after you PG, after you finish your exams. So there's something which is more happier thing waiting for you. So you think of that whenever you feel like demotivated, you think, once my exam is done, what all I'm going to do. So if you think of that, that should give you a more of motivation. Don't try to come out of the stress. You will never be able to come out of the stress. Every time you try to remove this anxiety from you, you will get more anxiety only. Yes, got it, Ranjan. Don't feel bad about getting anxious. That is normal. That will happen. With that, you concentrate on your work and you just move ahead. Once your exams are done and you pass your exam, all that will be flying away. Next question. Ma'am, I'm unable to remember everything. But whenever I read the question, I do the right answer. Exactly, Ranshan. See, that is the other thing I wanted to tell you. Other question students were raising. Ma'am, whenever I read something, I feel like forgetting everything. Now only I read, ma'am. Last week only I read, but I'm not able to remember. See, I will tell you this. This is a very normal feeling to have this feeling of forgetting everything. Who will have this feeling? Only if you are preparing sincerely, only if you keep on stuffing things into your brain, you'll have a feeling that I'm forgetting. If you don't have this feeling, it means you're not reading properly. Only if you're on the right track, you will have this feeling. Last week only I read this topic, but I'm not able to remember. See, when you stuff so many things into your brain, it's all jammed there. So it'll be like that only. But I'll tell you, when you go and sit in your exam, on the day of your exam, when the question paper is given to you, when you see the question one by one, you look at one question from all that jam-packed stock of so many days, easily you will be able to retrieve the answer for that question. Now it is looking like all 19 subjects are jammed there. But in the exam, it is not the case. You are going to look at one by one questions. So one question you look at, easily you will be able to recollect the answer. You are going to think of the answer only for that question. So now it will be a confused state. But when you go to the exam, it will not be the state because you have stuffed so many things. On the exam day, for that question, if you think about the answer, you will get the correct answer. See, Ranjan is saying the same thing. I'm unable to remember everything. But I do the right answer in the exam. Correct. Exactly that will happen. So don't worry about forgetting things. Only if you are on the right track, you will have a feeling that you are forgetting things. If you don't have the feeling, it means you're not studying properly. Yes, every section is not the same. So that is not in our hands. So you just leave that because anyway, it is not a competitive exam for you. Please remember, you are not going to compete with anybody else. Dheeraj is not going to compete with Ranjan or Ranjan is not going to compete with Siddhi. You are not fighting with anybody. You go, sit and write your exam. You are going to pass your own exam. You are just going to get eligibility for your own self. You are not going to pull into anybody else's mark. Or if someone else is going to get a good mark, it is not going to affect you in any way. So don't have any comparison and don't think about the sections are different, standardization is different. Don't worry about all that. You go write your exam sincerely. You pass your exam. You are just working for an eligibility in your exam. When you move on to NEET PG, the next step you can worry about all this. There you have to fight. Ranjan has to fight with Dheeraj. If both of them are getting the same rank, we won't know who will get that PG seat. But now it is not the case for you. This is actually a very happy exam for you. You read for yourself, write your own exam. No need to compete with anybody else. Just get an eligibility for your own self. Okay. Yes, these are the few things that students were messaging me, and I want to tell to everybody. Yes, so let's learn happily. Let's do it happily. See, whatever you get anxiety or stress or whatever is that, the exam date is not going to change. Exam is not going to change. We have to face the exam. So I have faced so many exams. Every time before the exam, I will feel sad. I will feel depressed. But once the exam is over and I get good marks, I'll be the very happiest person. So after every exam, I'm feeling that. So all of you will have the same feeling. Fine? Yes, we'll go to CVS, cardiovascular system. Yes, the first one, Poiseuille-Huygens law. Poiseuille-Huygens law. What is Poiseuille-Huygens law? Flow is directly proportional to fourth power of the radius. This is Poiseuille-Huygens law. I'll write the complete law. This is only a part of it. The complete law is flow is directly proportional to pi into delta P into r to the power of 4 divided by 8 times viscosity into length. This is the complete Poiseuille-Huygens law. Pi into delta P into r to the power of 4 divided by 8 times viscosity into length. Yes, now answer me this. If you double the radius of a blood vessel, what will happen to flow? If r becomes 2r, what will happen to flow? It will become 2 to the power of 4. So that is 16 times. So flow increases by 16 times. That was a repeat question. If R becomes 2R, then flow becomes 16 times. Yes. If R becomes R by 2, if you half the radius of the blood vessel, what will happen to the flow? Now it becomes 1 by 2 to the power of 4. So this is flow decreases by 16 times. If R becomes 2R, flow increases by 16 times. If R becomes R by 2, flow decreases by 16 times. Yes. This is called Poiseuille-Huygens law. Over to cardiac cycle. Very important topic. Cardiac cycle. This diagram was given by Vigor. So it is called Vigor's diagram of cardiac cycle. First of all, what is our understanding of cardiac cycle? Cardiac cycle means every time your heart beats, for every heartbeat, what is the volume change inside the heart? What is the pressure change inside the heart? So this is called cardiac cycle. For every heartbeat, volume change and pressure change inside the heart. That is why in the cardiac cycle diagram we have volume curve and pressure curve. Simple. For every heartbeat, what is the volume change? What is the pressure change? So pressure changes, volume changes. First, we will listen very carefully, please. Cardiac cycle, very complicated, important topic. Pressure changes inside the heart. There are 3 pressure curves in the cardiac cycle diagram. The topmost pressure curve, I'll trace that in green now. How will you identify this curve? You just look at the pressure variations. It starts at 80, goes up to 120. What is 120/80? Your normal systemic blood pressure. We record the blood pressure in the brachial artery. But it is not the pressure which started in the brachial artery. It is the pressure which started in the heart. The first blood vessel from the heart. Aorta. Aorta only had this 120/80 that is transmitted to your brachial artery. Because it is easy to do, we are doing it on the brachial artery. Actually, what is 120/80? Aortic pressure. So whichever curve has 120/80 denotes aortic pressure curve. Simple. 120/80, if you see a curve, aortic pressure curve. There's a big red colored curve. I'll trace that in red now. This one. Look at the pressure variations. It starts from 0 to 120. Such huge differences in pressure. Only a huge chamber can produce. Big pressures, only a big chamber can produce. Which is the big chamber in the heart? Atrium or the ventricles? Ventricle only is bigger. So this big one belongs to ventricle. This is called the ventricular pressure curve. Ventricular pressure curve. There's a small curve. We'll trace that in black. Look at the pressure variation, not even 20. Very small differences in pressure. A small difference in pressure, only a small chamber can produce. Which is a small chamber? Atrium. So the small curve belongs to small chamber, atrial pressure curve. That's how we identify the pressure curves. What about the volume curve? There is only one volume curve. Which volume is more important for us? Ventricular volume. So this belongs to the ventricle. Ventricular volume curves. There's only one ventricular volume curve. Now, phases of cardiac cycle. What are the phases of cardiac cycle? We have identified the curves. What are the phases? Every time your heart beats, what is a heartbeat? Heart is contracting, relaxing. It means systole, diastole. So what are the phases of cardiac cycle? Systole and diastole. We have atrium and ventricle. So you have atrial systole, atrial diastole, ventricular systole, ventricular diastole. So I'll mark the phases of the cardiac cycle. Atrial, systole, atrial diastole. Atrial diastole is very insignificant. So you leave it. This is followed by ventricular systole and ventricular diastole. So we have atrial systole, ventricular diastole. So this is how we identify the phases of the cardiac cycle. So now here, in between this, we can fit valvular events. How do we fit valvular events into this? At the end of atrial systole, the atrium has contracted, pushed blood into the ventricles. After atrial systole, once atrial has contracted, excellent Ranjan, when atrium has contracted and pushed blood into the ventricle, AV valve will close. So at the end of this atrial systole, AV valve closes. This is atrial systole. At the end of atrial systole, AV valve closes. Now, ventricle is filled with blood. So, when this ventricle is filled with blood, which valve will open now? Aortic valve is going to open. So, this is followed by aortic valve opening. Now, in between these two, we have a small period. I'll put that in yellow color. So, this small period where AV valve has closed. Aortic valve is not yet opened. It's just going to open. AV valve has closed. Aortic valve is going to open. A small period where both the valves are closed. If both the valves are closed, the volume in the ventricle cannot change. There's no outlet. So this is called isovolumetric phase. This yellow phase is isovolumetric followed by contraction. So it is isovolumetric contraction phase because it is followed by ventricular systole. Isovolumetric contraction phase. Once aortic valve opens, blood is pumped into the aorta. This is the aorta. Once the aortic valve opens, blood goes into the aorta. That is, ventricle is contracting to push blood into the aorta. So there is ventricular systole. Once blood has gone into the aorta, this aortic valve will close. So now aortic valve closes. When aortic valve closes, again which valve is going to open? AV valve will open. Here also you have a small period where aortic valve has closed, AV valve is going to open. Small period where both the valves are open. Both the valves are closed. So if both the valves are closed, again it is a isovolumetric phase. But now it is isovolumetric relaxation phase. So when AV valve opens, all blood flows into the ventricles. Ventricular diastole. Ventricle is getting filled up. This is called ventricular diastole. But ventricle will fill up in 3 phases. Initially, there is more pressure difference between atrium and the ventricles. Atrial pressure is more, ventricular pressure is less. Because of the pressure difference, rapidly blood pours into the ventricles. This is called rapid filling phase. More the pressure difference, more rapid is the filling, rapid filling phase. As the pressure gradient is destroyed, now it becomes slow filling phase. Slow filling phase. At the end of the slow filling phase, there is no pressure difference at all. Both atrium and the ventricle, same pressure. There's no pressure difference at all. Now there is some more blood present in the atrium. Now how will you push this blood? There's no pressure difference. Now how will you push? Now atrium will contract to push blood into the ventricle. So only in the last part of the filling, atrium is contracting and therefore there is filling. And therefore there is filling. So rapid filling and slow filling are because of pressure difference between atrium and the ventricle. Atrial pressure is more, ventricular pressure is less. So it is rapidly filling, then it's slowly filling. At the last part, atrium is contracting to push blood into the ventricles. These are the filling phases. Now we'll place heart sounds into this diagram. How will you place heart sounds into this? Whenever a valve closes, you hear a heart sound. AV valve closure, S1, first heart sound. Aortic valve closure, S2, second heart sound. S2, S1 and S2 are called lub-dub sounds. Lub has a significance. L for loud sound, L for low frequency sound, and L for long duration sound. L, lub, loud, low frequency, long duration sound. Yes. Dub is exactly opposite. There is a third heart sound. Sometimes during this rapid filling phase, you can hear a third heart sound, S3. That is because of the turbulence. Rapidly when blood is flowing, the turbulence will create a noise. So that is rapid filling phase, S3. S3 is normally heard in children, pregnant women, athletes. Physiologically, it is heard in high demand states like children, pregnancy, and athletes, and pathologically in heart failure. This is not love failure, this is heart failure. Pathologically, it is heard in heart failure. This is S3. So, S3 can be heard physiologically and also pathologically. Sometimes after this also you can hear S4. S4 is heard during the last part. When atrium is contracting and pushing blood into the ventricles, you hear S4. See, if your ventricles are normal, you will not hear S4. But if the ventricles have hypertrophied like this, left ventricular hypertrophy. Now, if the atrium is contracting against a hypertrophied ventricle, you hear a noise. This is S4. Normally, when you close and open the doors, there is no noise. But during rainy season, if the wood has expanded, now you close and open the door, you will hear a noise. So if the valves are normal, if the ventricle is normal, you don't hear a noise. But if the ventricle is hypertrophied, then only you will hear the noise. So S4 is heard during left ventricular hypertrophy. This is how we correlate the cardiac cycle events. This is about the cardiac cycle. Next, we'll move on to the pressure volume loop of the left ventricle. The same cardiac cycle. Yes, Dheeraj, like the horror movie, exactly. Slowly the door opens and closes. Normal pressure volume loop of the left ventricle. The same cardiac cycle diagram we had learned, but in the form of a loop. This diagram has volume in ml on x-axis and pressure in millimeter of mercury on y-axis. What is this pressure volume loop? I'll just mark the parts of the pressure volume loop. 50 ml is called end systolic volume and 130 ml is end diastolic volume. It means if your heart is fully filled with blood, it can hold 130 ml. For every stroke, so what is 130 ml? End diastolic volume is 130 ml. So this heart is filled with 130 ml. But nobody's heart will be able to push out all the 130 ml. Every time your heart is striking, for one stroke, only 80 ml comes out. So that is called stroke volume of 80 ml. Every time your heart is striking, 80 ml comes out. After 80 ml has moved out, 130 minus 80 is 50 ml. So at the end of systole, after 80 ml has moved out, at the end of systole, how much blood is remaining in the heart? 50 ml. So 50 ml is called as end systolic volume 50 ml. So end diastolic volume normally 130 ml. For every stroke, 80 ml goes out stroke volume. After sending out 80 ml, 50 ml remains in the heart. That is end systolic volume. So in the diagram, this is end systolic volume. 130 is end diastolic volume. Now what is happening in the heart from 50 to 130? Heart is getting filled up. So D to A is filling phase. This is filling phase. Once the ventricles are filled up, now AV valve will close. So at the end of this, at point A, AV valve closes. Now which valve will open? Aortic valve will open. Aortic valve opens. What is A to B called as? AV valve has closed. Aortic valve is going to open. Yes, both valves are closed. This becomes isovolumetric contraction period. That is why during A to B, volume remains same at 130, but pressure increases on y-axis. Isovolumetric contracting. That's why pressure is rising. Volume is same, pressure is increasing. Once aortic valve opens, blood is ejected into the aorta. So this is ejection. After blood has been ejected into the aorta, aortic valve closes. Aortic valve closes. After that, again AV valve will open. AV valve opens. Then what is C to D? Aortic valve has closed. AV valve is not open, just going to open. So there will be a small period. Both valves are closed. Yes. Isovolumetric relaxation period. That is why volume remains same at 50 from C to D, but pressure is decreasing. It means it is relaxing. This is isovolumetric relaxation period. This is the normal pressure volume loop of the left ventricle. Yes, before we move on to JVP, I think we'll have a coffee break and then we'll move on to JVP. Yes, I had a break slide for you. So we'll have a break. Yes, maybe a coffee break till 4 o'clock. Yes. So till 4 o'clock we'll continue. Thank you. Please have a break, relax and come. We have renal and endocrine.